Okay, thank
A warm welcome to everybody who is joining in today. We're fortunate to have over 600 people registered for today's session. As we wait for everyone to come in, we are at almost 200 people in less than 30 seconds. Again, for those of you who are just joining, a warm welcome. We have over 600 people registered today from Canada, across North America, and the globe. This is the beauty of the International Foundation for Integrated Care. It brings together people from all over the world to converge, convene, discuss, learn, grow, but most meaningfully have important impact and partnership with patients and caregivers on health and well-being in every country. A warm welcome to all of you. For those that are just joining, welcome. We have over 600 people who are joining today, who have registered for today, and each of you is logging in now. A warm welcome. As people log in, we are very excited today to present our next International Foundation for Integrated Care Canada virtual community. I am Jodine Goldhar. I am co-founder of the International Foundation for Integrated Care Canada.
Welcome everybody as well. My name is Walter Wojcik, and I am also co-lead for the International Foundation for Integrated Care Canada and lead for our co-sponsor today, the Health System Performance Network. I am so pleased we have everybody here. Maybe we could go to the next slide and let everybody know to join in. And one more, yes, to use the chat to join us. Go ahead.
As you're joining, the key to success is how we use the Zoom virtual platform. Walter and I, our goals is to make this as engaging and collaborative as virtually possible. And so what we find in these sessions, and given how many people are joining us, is in order to do that in the chat, please make sure when you're using it, you press to all panelists and everyone. A lot of people participate accidentally by just pushing to all panelists. So please make sure that you do that. We will, of course, send out reminders. We also want to engage those that can't be online today, but care very much about the conversation we are having around collaborative governance. Feel free to tweet. This is the hashtag that we would like to use, and feel free to tag Walter and I and any of our participants today so that we can join you online. You're welcome to take pictures, add any content so that others can join in this incredible opportunity. Now, many of you are already doing this, which is incredible. We're at almost 300 people online to the IFIC Canada virtual community. Today's topic is collaborative governance. And as those of you who've been here before know, these sessions are open and we get responses from all over the world. So as you're logging on and already doing, share in the chat, say hello to everybody. And you can see already that we have spanned different parts of Canada, United States, and the globe. Say hello to each other. No doubt many of you know each other, as HSPN, our key sponsor for today, is in Ontario, but IFIC Canada is across North America. And so many of you don't know each other, and this is an incredible opportunity to strengthen our community, share all of our knowledge around today, collaborative governance, and build all of our capability to make a difference.
It's truly amazing. I think our first entrant on the chat was from Galway, Ireland. And I just saw, I'm looking back for the name, Ethiopia. And I see here more Ireland, North Carolina, all across Ontario and Canada. So it's a wonderful audience today. I'm really happy to have everybody joining us. In Canada, we have a tradition of acknowledging the land upon which we operate. Today, I am speaking to you from the University of Toronto, which is the land traditionally of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. We also acknowledge that Toronto is covered by Treaty 13 with Mississaugas of the Credit. All across Canada, you are coming to us from areas that are home to many diverse First Nations, Inuit, Métis peoples, and each of you joining us from those traditional lands. I encourage you to acknowledge the land from which you are coming to us today, and we're grateful to be able to come together in this way. Thank you. We'd like to launch our first poll to understand our audience today and to see who is new to our group.
And one of the reasons we do this is we track over time through all of our sessions, how many have joined us before, how many of you are joining us for the first time. So please feel free to respond to the poll. And of the 330 people who are online right now, we will have a good sense together who has joined in the past, who is joining for the first time today. And I would imagine, as has happened in the past, the conversation we're able to have virtually and through the chat really builds on conversations we've had of the past, but also gives an opportunity for those that are here for the first time to see how powerful our collective contribution can be through our virtual community. Fiona, thank you for launching the poll. I think it's okay if you close it. Okay, so we have about 40% of us, rounding up, who are joining for the first time today. A warm welcome to all of you. We hope that you will join us again. And for the 63% or 132 of you that responded to the poll, welcome back. We're excited for your contribution. As you know, we have panelists here, but of course, it's all of you that contribute additional value as part of the topic we're going to be looking at today. So let me tell you a little bit around our virtual community. Our virtual community was designed around a number of core principles. Now, these core principles are very similar to some of the core principles that are about collective governance, collaborative leadership, or collective impact, because we see ourselves as a platform to curate the collective, to build the capability of the collective, and for each of us to be more powerful in our individual and our organizational impacts than any of us can do on our own. If we go to the next slide, we have been building topics that are crowdsourced. So everybody who participates in the virtual communities actually informs the next iterations of our virtual communities. And you can go back on the IFIC Canada website, which is hosted by the International Foundation for Integrated Care. If you go to the website and then go to Hubs, you'll see IFIC Canada. Under there, you have all of the topics that we have ever covered. And they are still extremely relevant. So you'll have a global tour on integrated care. You'll be able to see co-design, equal partnership with patients, clients, consumers, caregivers, as part of both defining, designing, and delivering integrated care, and many other topics. So please do go there. In addition to that, you will find on the IFIC website around the conference we hosted. It was the first North American conference on integrated care, and it was about co-designing for health and well-being with people and their families. And one of the reasons this was so important, it is one of the first conferences in the world to have equal partnership with patients, clients, and caregivers in the design, delivery, and attendance of the conference. And we partnered in a new power approach where we share the power for decision-making, delivery, attendance, and understanding with those that work in health and social care, policy, funders, researchers, people who deliver care, along with people who receive care and people who support people who receive care. There were 5 plenary sessions from international speakers, and you can access all the plenaries and all the sessions. So please do go look at that. Now let me start off by introducing today's session, collaborative governance. And you can already start to say in the chat why you joined today and why collaborative governance is important from your lens. For me, as a person who helps hold space for multiple people, multiple organizations, multiple viewpoints to come together in shared purpose and be able to make breakthroughs so that we can, in fact, create, deliver, and be experienced as an integrated system of care, one team that is focused on what's most important to people and their families, which will ultimately enable population health and well-being in our communities and around the world. What is most important for me is the how, not the what, not the structures, but the how. How we build the radically collaborative nature that ensures we can work in a collaborative governance way. And collaborative governance is a key enabler, a fundamental enabler for integrated care and population health. But the critical piece is how we do it. And so Walter and I are incredibly proud and excited for the kind of conversation that will emerge today and the knowledge we're going to share with each other. And as that's happening, please feel free to share why this is important to you. And some of you have said to ensure that all voices are heard and considered. Thank you, Jennifer. Colleen, distributed leadership, the values, all the point of views and experiences. Alex from Scotland, hoping the citizen is the point of integration. We will all be speaking to that. Thank you. To you, Walter.
Thanks so much, Jodim. And we are really set up for a fantastic event today. And people, I encourage people to identify why governance is important to them. And people are popping that into the chat right now, exactly as you'd asked, Jodim. So we're going to gather quite a bit of great information about what's important about this. And we'll read a few of these out along the way. We had some goals today that we shared with our speakers. I'll get to introduce them in just a second. First off, understanding the evidence and research. We like to bring the science to set off the foundation of what's known. And we'll have Dr. Mirella Minkman lead off our day on that. Understanding the role that collaborative governance plays in policy and program delivery, highlighting successful approaches. And we have some examples today from our front lines in Hamilton and in Barrie area, from both the leadership and the patient caregiver perspective on those, and then to understand how collaborative governance approaches are built and sustained through practical examples. So those are the kind of key goals for us today. The speakers, as I've indicated, we have first Professor Dr. Mirella Minkman, who is chair at the board of directors for VILANS, which is the National Center of Expertise in Long-Term Care for the Netherlands. Very particularly, Mirella is also the endowed professor of innovation, of organization, and governance of integrated care at the Tilburg University TS Business School in the Netherlands. And you can see why we asked Mirella to come and share some of her insights and knowledge today, really the global expert in this area. And she's really got a strong focus on that organizing person-centered care between people and organizations and networks, and what governance structures are needed to support them. Paul Wankah, Dr. Paul Wankah has been working with me as we've tried to understand this in Ontario, and we're going to share some of our summary of what Ontario health teams, as our example, what the forms of governance are, how they're structured, and some key summary measures that we captured from all of the leaders from over 750 surveys that were completed earlier this year. Melissa McCallum is the first executive director for the Greater Hamilton Health Network, having been appointed in October 2021. Her history is as a registered nurse with 16 years of leadership experience in healthcare, previously as a director with the HNHB Lynn, and has a passion for working with partners to create integrated equitable health systems, and was also the recipient on behalf of the Hamilton Health team at the International Conference on Integrated Care last year for the Innovation Award. And Donald Carty, and I have just met Donald Carty recently. Very, very pleased and honored to have met Donald. He plays an active role offering diverse voice at many health and wellness planning committees across city, municipal, and provincial levels throughout Ontario and across Canada. He is here. We invited him. He is co-chair, patient co-chair of the Barrie and Area Ontario Health Team, where he's also served as a patient family advisor, and bringing to us today an understanding of what is important about governance to patients, families, and caregivers. We really aim to, and EFIC Canada always have that voice included in our perspectives and summary. So really looking forward to hearing from all 4 of our speakers. That's the introductions. We will just fly through when the time comes for them to start. Also making it happen in the background, Tricia Martin, Deb Golub, Niamh Dalliday, and Fiona Line, all helping us launch this. They're sitting in the background here. They are launching the polls, they are moving the slides, and ensuring that this is a smooth event, also managing the registrations. We have one more poll just before we get started, and that is to get a sense of what knowledge level you have coming in here. So how knowledgeable are you about the role of collaborative governance in integrated health systems? So if we could launch that poll and collect it and start pulling in people's thoughts on this. And let's see, we're at over almost 370 people now online. So let's see, from very knowledgeable down to not very knowledgeable at all. So let's see how people land on this. Please click in and submit.
One of the reasons we do this is we like a baseline on where you're at in terms of your own perception of your knowledge. And we do launch the poll again at the end of the session to see if that has shifted. It's a measure of how successful we were in helping build all our capability and understanding.
Okay, so I think great, we can take that down and share it up. We have actually a little bit, we can probably scroll down just a tiny bit, you're seeing just 3/4 of it here, that the most people are on the upper side this time, Jodine. So people are starting off with a little bit of knowledge, somewhat knowledgeable, 37, and then another 30% up ahead of that. So a fairly knowledgeable audience. We're gonna have to raise the bar and challenge people in their understanding today. Excellent, thank you very, very much for putting that up. And so now, without further ado, we are going to start in with Dr. Mirella Minkman. I'll ask to come off mute and join us today and share her knowledge about integrated care governance. Welcome, Mirella.
Thank you, everybody, and thanks for this great invitation to be here with all of you, just from the Netherlands, sharing our experiences with you about, I think, a very important topic about collaborative governance. And it is exactly what Jodine says. How do we do it? How can we learn from each other? So I hope I can contribute a little bit to this topic in the next 15 minutes. Can I have the next one? Thank you. Well, the introduction was already done by Walter, so I suggest we don't spend time on that. It's always something about my background. But the most important thing is that my passion and motivation is about how we organize integrated services better around people, and also what it means, what kind of governance do you need. So that's the main topic of all the work I do. It's all about knowledge about these kind of topics and how we really make it happen in practice. So let's start off with the next slide. Yes, because we have to move forward. You have to move forward in Canada, North America, but also in Europe and everywhere around the world. And we do have some challenges. And I think we can learn of each other because we do have some same challenges also at the same time. I don't have to tell you again about the changing demographics, the shortage of staff, which is really getting more and more urgent also in my country, but also the need for involving communities and civilians and about, you could say, everybody. And how do we do it? How can we be more supportive communities, more supportive countries for the people who are the most in need? And I think that it's also important that we look again about how we organize and how we implement and have arranged our governance models. So, and by governance, I don't really mean on the national level with legislations and things like that, but how do we do our leadership? How is the steering on integrated service networks? How do we do supervision? How are we being accountable and things like that? So it's about that. How can we do that in another way so that we really support the aims that we want to reach? So, and we don't only need science, we also need your knowledge, we also need practice experiences, because we are on a kind of a time pressure, because we need solutions now. And of course, knowledge development sometimes always also takes time. So let's move forward, I would say, with this topic. Can I have the next slide? And if you look at this topic, and also if you look in a more broad view about the literature about integrated care, You mainly see four, you could say, large strategies to work on. Of course, strengthening communities, people themselves, is very important. That's a major strategy also to deliver another way of support and care for people. That's from a broad perspective, because a lot of topics and issues which are seen, which look like healthcare issues, are issues about the conditions of people, are about how they live, how they work. So it's not only about health, it's about that broad perspective. That's and when you look at that, it means that the healthcare perspective is way too narrow always to really have the impact that you want. So for healthcare workers, people who work in the field, and also leaders, it's very important to have more shared services and shared interconnected networks. And that's a large development we see worldwide, I see, but also in our country, especially also because now in the Netherlands we have also an integrated care agreement, where it's more obliged also to work together. So how do we do that? Because the governance is often focusing on the organization or on the professional. So we really need a turnaround in that governance. So of these four strategies you see on the slide, we now focus on the third one, who is about the how-to governance issues. So can I have the next one? Yeah, okay. So transforming governance, what to do and how can we make it work? Can I have the next one? Yes, thank you. So what we need is a little bit of turnaround. And as Jodine also said, it's not only about structures, but it's also, I would say, about how we do it and how we arrange it. It's not only about informal agreements and things like that. You need them all. So you need suiting structures. How do you organize it? What kind of agreements do you have? Who's responsible? How do you do decision making? You have to rethink that and arrange that. Of course, this takes time. You can't do it in one day or 1 year. These are multiple time. These are long-term processes. You have to learn, you have to build, but you also have to involve people, because the commitment is very important. And also a next step is that you don't have to work only about your structure, your leadership, and who's involved. It's also about another way of being accountable, another way of arranging supervision about quality, but also more external supervision, you could say, about are doing healthcare providers and leaders the right things. So you need them all. So it's a kind of a puzzle, you could say, and it's really a learning in progress. So that's why the arrows keep going around and around, and you have to refresh and adjust and learn over time. So next slide, please. So there are more pieces of the puzzle, and we only have short time periods, so I can't explain them all to you. But that's just let's dive into them and look at some of the pieces of the puzzle. I will start with the network modality. And in this slide, it was the green thing, because the citizen involvement, because I'm working now more and more on that. And I think that's a very, very important piece of the puzzle where we really need more knowledge about. So I think it's very good to also have the citizen or patient or perspective on board, literally on board, you could say. Okay, but let's start with the network modalities. So how do you do it? The inter-organizational connections. How do you make the connections? Well, of course, it's good to see what kind of options do you have? What kind of choices are there to make? Can I have the next slide? Oh, you can go to the next slide again. Yes. Yes, thank you. Okay, because it's all about connections. It's about relationships. What kind of form, what kind of structure, you could say, is suitable for that aim that you are working on. So here you can see some of the options there are. So with how many organizations are you working? Is it only 3 maybe, or do you have 30? So also what kind of modality suits the way you are working and that you can really achieve results? Here you see just 5 options from the work of a colleague of mine of Tilburg University. And for instance, you can think about, do you need one lead organization? So do you want to have a structure where you say, okay, we work together, for instance, as 10 different organizations to reach the aim, because we can't do it alone, but we need one lead organization, and we accept that, we arrange that, and the lead organizations make agreements with the other ones. Maybe that's not the most suitable structure. Maybe you don't need that. So you are all equal, you could say. Or maybe you need a structure where you say, well, we need one organization who is not really a party, you could say, that also is delivering support or care, but is a party that's helping the progress and helping the collaborative process. So that's, you could say, it's a kind of a glue between all the participants in these kind of services. That's also a possibility. And maybe you need both. Maybe you say, okay, I need a kind of a collaborative model in which we have a difference between parties and organizations who are more involved, you could say, like in the fifth figure, and we have others who are also very important, but to steer it and to make progress, they are a little bit more, you could say, a little bit more on the informational level than really also steering our collaboration. So the conclusion of this slide is that there's not one perfect model, but it's very important to see what fits your situation. Because when you choose a kind of situation or one of these models, you have to make arrangements to each other. And there are also different balances, how you build relations, how powers are divided, how maybe decision making is organized, etc. So next slide, please. So there are some lessons, you could say, which I already explained some about. Very important that if you work on the governance, it's not really a project. It's not a time project where you say we start and we end and we work on that. It's really something that has to be durable over time. It has to be sustainable over time. So working on new modes of governance is something for the long term. So you can't just fix it with project groups and steering boards and things like that. You have to evaluate it and also see, is this really working? Are we really working together with all the parties that we need now or not? So maybe another organization should be included in our collaboration, or maybe one who is included should not be included anymore. You have to dare to evaluate and to change to make the best outcome for the persons and citizens where you're working for. So next slide. So, and also you have to think about what's the kind of scale, what's the object, what are we working on, what's the area we are responsible for. So that's the issue about scale. And there are some publications about scale issues. Are you working local level? Are you working on regional level? And what exactly is then the local level? Do you have all together, with the organizations you're working on, the same idea about that? So next slide, please. So this is just one piece of the puzzle, you could say, but of course there's more, because when you want to make progress, you also have to think about how do we make decisions, because that's very complex in such a situation where you have a collaborative governance model, because it's not just the one single organization with the board of directors who can decide whatever they want, you could say. Can you go to the next slide, please? Yeah. So decision-making in collaborative models is quite complex, you could say. So, and what we see is that there's often not enough attention, I would say, for the decision-making process. But it's very important, because only by good decisions who are really also adapted and work on in practice, you get progress, and that's important. So what's the complexity about the decision-making in these inter-organizational collaborations and these networks? Okay, go to the next slide. One of our colleagues did some nice research about that, and it's just been published in the International Journal of Integrated Care, because decision-making in inter-organizational networks or in collaborative models is quite complex, because you work together, because you are interdependent of each other. But at the same time, you experience that persons, people, but also organizations really think that autonomy is very important. So that's a kind of tension, or maybe a dilemma. How do you deal with that? Another important dilemma is that you work together because you are different. Because otherwise, if you can do it all by yourself or alone or with your own team or whatever, you don't have to really collaborate. So you are diverse, and the diversity is very important. But at the same time, you are striving towards coherence. You want to achieve something together. So you are different, you have different views, different ideas, backgrounds, and things like that. but you strive towards coherence. So that's you could say it's a dilemma which is already present because of the way you are working and collaborating. And the last dilemma is that you want to strive to common goals. You have a nice ambition. You want to have better services, better support, care, whatever you are striving towards. So you have a common goal where you're working towards. There's a kind of a basic assumption for working together. But also there are interests of the different organizations themselves, of the different professions, the different people. So there's also the third dilemma, which is balancing between the common goals and the self-interests. And that comes together in the dilemma of how you arrange your decision-making. And the dilemma is the balance between efficiency and also inclusiveness. Because you can imagine, you want to be inclusive so that everybody is involved, everybody will agree, but that can be very time-consuming. So how do you balance about these things? And what we learned and also see, can I have the next slide, is that you don't really have to choose for one option, because you also can see, you can decide that different decisions can have different models made. So that's also something to think about. So if you have a kind of a way of working together or a modality, you think about how do we do the decision making? What kind of approach fits what kind of decisions? And how can you balance between efficiency and inclusiveness? And you have options. Of course, the most efficient option is that you say, well, decisions can be made by one person and we only give them advice, or one organization. But you can imagine that does something with inclusiveness or adoption or whatever. And you have also other options for where you want to have everybody who's agreeing. So decision making and thinking about how you do these processes, what kind of way of working for decision making do you integrate into your collaborative service and your collaborative governance is very important. Can I have the next one? Okay. Another topic which is very important and what's also getting more and more interest in our country, the Netherlands, and hopefully maybe also in your country, is not only about how you arrange it with each other, but also what does that mean for supervision, for external supervision, for instance, of quality inspectors, but also for the supervisory boards you have. Because, for instance, in the Netherlands, all healthcare organizations do have, of course, their CEOs and their boards, but we also all have supervisory boards. And they are trained to look at the organization. They feel responsible for the organization, but the value is being delivered in the collaboration. So you have a collaborative work agreement with other social care, healthcare providers, or whoever. So there's a collaborative aim, a collaborative goal, you work together, but the supervisors are focusing on the organization. And they are a bit worried, how do we do that? We have all these collaborations, and one organization is not involved in only one organization, one network, they are involved in multiple networks. How do we do other modes of supervision? So we're now starting a new research from Tilburg University and Amsterdam University to really co-create with practice other ways of supervision that really are focusing on the inter-organizational arrangements, focusing on the aim that you want to deliver together. Okay, can I have the next one? Yes. So let's skip a little bit to the more relational aspects also of the collaborative governance, because you have to work together and it's all about people, relations, and how to work together. So the circle is a little bit in between because I couldn't choose, of course, but I had to choose a little bit because of time. I want to tell you a little bit about the importance of underlying values, because values drive behavior of people, and also the involvement of just old people, because we need more governance models that was not really focusing on just having organizational models without all kind of hierarchies and etc. We have to involve the people who are really affected by the services, who can express what could be the right services and support. So the people themselves, the civilians, the patients, or whatever name you want to do for the people who are just like you and me. So let's go to the next slide. So to understand a little bit about this is what the work of Nick Sonneveld, which is a colleague of mine, who is working on his PhD and is focusing on what are underlying values which are important for decision-making, for driving behavior of people. So you have to also pay some attention, how do we work together? What do you think is important? Why are you working with me or not? Because, and it's important because if you don't see what kind of values are underneath, then it's also sometimes more difficult to understand behavior and also to talk about other things than just about activities, tasks, processes, budgets, and things like that. What's important? Why is it important to you? And what are your value priorities? What's more important and what not? So we can't go through all this work of Nick, but what's most important to remember, and our number of publications also to read a little bit more about it, is that it's also important to discuss with each other what kind of values do matter to you, what kind of values do matter in your integrated services, how you want to work together. And what we also discovered in his work is that its values do differ. They are different. So we also see that, for instance, professionals do have other value hierarchies than patients, do have other value hierarchies than, for instance, policymakers or finances. So people are, of course, diverse and look from a different perspective. Most of the time, they do have good intentions, but the values are different. And you also have to think and realize about these kind of aspects. So can I go to the next one? So how can we also come to more inclusive and more collaborative governance models? Also, where we involve the people who are we are working with and for. And the pictures are in Dutch. I apologize for that, but maybe you can imagine a little bit about what's on the slide. So what we need is also more and more, because what we see also in our country is that there's a shortage of a lot of things. There's a shortage of staff. There's a shortage of budget, you could say. So we have to make choices in the future. And the choices will be not that easy, maybe. And it's good to make choices also for what do you do, what kind of services can we deliver, what's not possible anymore. What do we expect of people themselves, to have these kind of discussions, to make these kind of decisions also with the people themselves. So we need to involve society, you could say, also in our governance models, the people who are working to and for. But how do we do that? That's not that easy. Of course, you can say it, but how can we organize and arrange that? I think we're now in a time frame that it's very important that we work on that we experiment with that and see what's work and how can we do that. So we have to move forward from the way of, well, asking people to sit down in formal committees with agendas and minutes and things like that, to have a more dialogue and a conversation about what's the right way to work together, what are the aims, what choices do we make, and also enrich ourselves with that perspective of the people themselves. And we can do that in a lot of ways. So there's not, I think, there's not one option or one way to do that. What we see, for instance, that using also the wisdom of the crowds, there are some nice methods to do so. For instance, like the deep democracy methods, to use them also in your governance. How can you do that? How can you use the wisdom also the people who are silent and you don't hear at the first moment? Also, we can use technologies also to listen to people, to hear their voices, to get input, especially when it's about a large amount of people. So just a little to explain in this webinar, with using a poll, you can very quickly ask on all of you what a question or an opinion or whatever. So that's a very quick way of having more an idea than just asking 3 people of you. So we have to be creative and also think, how can we do that and work that and integrate that in our governance models? And now in the Netherlands, we also see that in a lot of regions and communities, we're trying to have a kind of groups and councils of people, civilians, who can think about and think along also with people who are working in health and social care. So can I have the next slide? So different ways, also different examples. And this is, I think, an interesting example of something we learned in Finland. So the international learning is, of course, also very important. And we're very curious how it will work out, because they will start with it in January this year. We learned before when we visited Finland in the winter. But for instance, there they are trying to build up a governance model in which people from the county, the municipality, or different sizes, smaller or larger municipalities, they have a kind of a way of county elections. So people, just the citizens, you could say, can be elected, and they have a kind of a well-being county council. People who can have influence, you could say, on the board of that county, who will arrange and make decisions for the health and social care services in that specific area. And of course, someone has to work with the organizations. There is a CEO. But here you see just an example, and we are not sure how it will work out, but that's interesting to follow. How can you really involve people in a certain area also into the governance model? Well, I think we still have to learn a lot about that. But this is just an example about how in Finland they try to work on that. So I think the time is also now there to work on these kind of models and to learn and to experiment, also to have a more shared collaborative governance model where we mix the importance of having good modalities. So that was the first piece of the puzzle. Have clear ways and also fitting ways of decision making, because we have to make progress, and sometimes we can't decide everything with everyone. That's not possible. That's also not efficient. But we have to be inclusive, because what we do has to be supported by the people who are responsible for it. They have to be. It has to be supported by the people who are working in the health services, but also for the people who are involved in receiving the services and care, and also the way of working together with others, because it's something for all of us, because in the future it's very important that we see that health and services are really connected in society with all other life domains, like living, like housing, education, and things like that. So I think time's up for
Thank you very much, Mirella. So I think the vision on the next slide is really a useful one. So if we go ahead,
yes.
A lot to learn still.
Yes, exactly. I want to conclude by that, because I want to also share the floor with my colleague speakers. So I think we have a lot to do in working on new governance models. That's also a major step also for people who are leaders, who are in boards, for financiers, for supervisors. So it's something for all of us. So we have a lot to do. We have a lot to learn also from each other. But the good news is also not everything, but it's also a lot in our hands. So thank you for your attention, and I'll wish you also very much good luck in working on this important topic of collaborative governance.
Fantastic information and knowledge, and it's generated a lot of questions, some of which we'll get to in this, and some of which we'll try and organize for you again, Mirella, including people asking for some info on the well-being counties there at the end. We have been listening and speaking with Mirella for quite some time. Met with Mirella at the International Conference on Integrated Care last spring and asked her about what the key concepts were that they were studying. Also helped really to inform here in Ontario with the Ontario Health Team Initiative, having integrated networks of providers. We felt it was really important to understand the governance and what some of the ideas that Mirella has been talking about. You could go ahead with the slides up to Paul's first slide landing. Deb, thanks. And perfect. And so we asked Ontario health teams, because there isn't actually a lot of empirical work. There's some thought and theory in this space, but not a lot of empirical work to actually understand what are the governance aspects. And so we took some questions, and Paul Wankah, Dr. Paul Wankah, is going to go through some of what Ontario health teams look like, and in terms of some of the governance characteristics of the governance, and some of the points. I know it was raised a few times, including by Sharon Goodwin, this tension between individual organizations and shared purpose. We have some evidence on what that looks like in Ontario. Go ahead, Paul.
Yeah, so thank you, Walter. So can we go to the next slide? So just to put in a little bit of background for the international audience. So Ontario Health Teams are actually a product of a policy change. That's the introduction of the Connecting Care Act of 2019, whereby different provider organizations were encouraged to collaborate together and provide to be fiscally and clinically responsible for their populations and the individuals within their populations. So since 2019, the government of the Ministry of Health of Ontario has actually approved 51 Ontario Health Teams in different waves. The first wave was 30, then 13, then 8 waves in 2021. So among these Ontario Health Teams, like they had different representatives of organizations or the communities they serve, actually created what you call some sort of like a group that would help to steer the organizations towards much more connected care. And this is what we call the leadership group. So we were interested to understand like what is actually happening in the field in terms of like the way collaborative governance is actually enacted. Next slide. So we actually carried out 2 surveys, and we're trying to actually understand what are the main characteristics of this collective governance of Ontario Health Teams. And the survey specifically tried to capture the compositions of the different leadership groups and also how they perceived the way they functioned within their collaborative networks. Next slide. So the first survey actually focused more on the composition of the Ontario of the leadership group of Ontario Health Teams. So in order to actually carry out the survey, we contacted the evaluation lead of each Ontario Health Team. So we had 51 respondents that we asked questions about the size, changes in their leadership group or different governance models. So out of the 51 that we contacted, we just had 2 that we didn't include because one Ontario Health Team was still establishing its leadership group, and the other one gave us incomplete responses. Next slide. So there, the first results we actually saw was that there was some great variability in the size of leadership groups. The leadership groups actually range from 59 to 65 participants. Then we had like 1/3 of our leadership groups that had more than 20 members within the leadership group. And then there were like smaller leadership groups with about 5 to 9 members. Next slide. Then the median was about 15 members per leadership group. Then we also noticed that there was kind of like a certain level of stability in terms of like the turnover of the leadership group. About 74% of our OHTs had like a turnover of 10% from since they were inducted. And then there was just 12% that actually had like up to a quarter to more than half of the leadership group that actually changed since they were implemented. Next slide. Then we also wanted to actually understand how were these members chosen. So most of these members were really chosen to represent their initial signatory organizations, and also they were also chosen to represent specific health-related sectors like the acute care or the hospital or the primary care. Then very few, like just about 20% of OHT groups actually choose members to represent minority communities within the minority groups within their communities. Next slide. So our key findings in terms of how the composition of these leadership groups was that they were relatively large. That is like most of them, with a median of 15 members going up to 65 members. Then there was also relatively stable, like more than 74% of them had a turnover of 10%. Then most of them actually represented signatory organizations, with very few representing specific minority groups like indigenous, francophones, or racialized groups. So next slide. We actually now presenting about the how these groups were functioning. So what we did is we collected information from different members that could of the leadership groups, and we contacted about 1,423 in terms of like the survey distribution. Then about 387 people that actually were members of the leadership groups of their various OHTs responded. So our analysis was based on these 287 people. In terms of the distribution, some were present like in the primary care, that is like the primary care organizations, physician clinics and the nursing clinics. Then there is the acute care, the hospitals, then the communities. And next slide. So the very first, so the kinds of questions we wanted to understand is the decision-making processes that were involved, their level of commitments, how they actually monitored the implementation of the OHTs and their perceptions on the effectiveness of their Ontario health teams. Next slide. So in terms of the decision-making approach, we noticed that about 81%, that's like basically most OHTs, said that they made most decisions by consensus. So just like a minority were making decisions by membership votes. Next slide. Then regarding decision-making power, we also noticed that most respondents from hospitals, that is the acute care, they were more likely to think that decision-making, that all partners actually had equal influence in terms of decision-making, unlike the respondents from the primary care and the community organization that were more likely to think that some members within the leadership group actually had more power than others in terms of decision-making. Next slide. So in terms of the perceived level of commitment, most acute care respondents, they actually were more likely to think that they were more committed, they were committed to the level of the decision-making of the organization as compared to the goals of their OHTs. Meanwhile, those in the primary care and community, they were more likely to think that they were more committed to their organizations than to achieving the goals of the OHTs. Next slide. So in terms of the perception on the effectiveness, we also noticed that acute care respondents, they were more likely to rate the effectiveness of their OHT as excellent or very good as compared to respondents from the primary care and community who were more likely to actually rate a fair or poor performance of their OHTs. So in summary, please, next slide. So in summary, we actually, what we noticed that most OHTs actually make decisions through by consensus, and that most acute care respondents were more likely to actually think that every other person has that they had equal influence in the way decisions were made, and they also had more positive performance perceptions of the functioning of the OHTs in terms of like the level of commitment of themselves, how others were committed towards the OHT, and also in rating the overall effectiveness of the OHT. So thank you for listening, and we'll probably move to Donald for, no, I think, so.
Yeah, it's just back to I'll host and do the transitions here, Paul. Thank you very, very much.
Thank you, Walter.
Yeah, that's great. So I think it gives you a little bit of a flavor of some of the ways that OHTs are approaching this. We have a few other pieces, and we're going to be, HSPN will be releasing a report based on those governance questions in the coming months, 6 weeks or so. So watch for that. Just to report out on some of these differences. And, you know, I think we've been just learning, and this is a bit of ground, sort of getting a lay of the land at the ground level right now. And we'll see how this evolves over time. I think we also have some items in the surveys that relate to relationships, and particularly to trust, which was an essential element. And though it's not specifically part of the governance, it's a real enabling feature and a contextual. So some people have said, you know, what makes for better governance? Well, it really depends somewhat on the context, depends on how many people are involved, and depends on the level of trust that's incurring. If we could go ahead to Melissa's slides, that's fantastic. Introduced Melissa at the very beginning. I want to turn it over to her now to lead us through some of the experiences of the Greater Hamilton Health Network. And if you've been following the HSPN work on OHTs, you have seen a little bit of a flash on this in November 2021. As we were showing some leading practices, we had Melissa talking about some governance and primary care leadership and governance at the time. You can look back at that. So I've asked Melissa to come back and tell us a little bit about how things have gone in the meantime with their governing model, which has been to a not-for-profit independent organization. So tell us your story a little bit.
Thank you so much, Walter. Next slide, please. I thought I would just ground the presentation in a little bit about our Ontario Health team to start with. We were one of the first OHTs in the province to be approved, and that was in November of 2019. And our attributed population is actually quite large, one of the larger Ontario Health teams at about 620 to about 675,000 residents. And we span a geography of Hamilton, Haldimand, and a portion of Niagara. It's also important that we recognize our OHT supports individuals from 2 neighboring reserves, Mississaugas of the Credit and 6 Nations of the Grand River. So considerations for on-reserve and urban Indigenous care are very important to our OHT. I won't get into detail about our population, but I will say that we do have a mix of rural and urban communities, which poses its own, health and social challenges as we plan integrated care together. We have extremely high areas of material deprivation. Hamilton is one of the highest concentrations of urban poverty within Canada. We know that our senior population in all of our regions that our OHT is attributed to is growing. And mental health and addictions continues to be a significant local health burden. And these concerns have really only been exacerbated by the pandemic. Next slide, please. A little bit about our journey to date. As I said, we were approved as a OHT in 2019, in late 2019. At that time, we submitted an application to be a Hamilton, Ontario Health team, just concentrated on Hamilton alone. And we did get approved as a Hamilton team. The pandemic sits there in around March 2020, where we actually utilized kind of our OHT structure and governance as it was to come together under an integrated COVID response. In February, we learned that we would actually be integrated with 2 other regions. So that posed some interesting challenges as we were thinking we would move along as Hamilton proper. We actually brought in another region, Haldimand. We did a huge rebranding to reflect our full attributed population. And I will talk about the journey that we actually became the first incorporated Ontario Health team in the province in December of 2021. Next slide, please. So, the most common question is why did we decide to do this? Why did we move to a not-for-profit incorporation at a time where consensus decision-making across the province was the model that was used by Ontario Health teams? And, much to what Mirella was saying, this was all about relationships. We decided that our Ontario Health team would really be that glue to bring in organizations to think about the well-being of our entire population. We already had extremely mature partnerships in the region. I will say from decades of working together on integrated initiatives. So I really felt that, we really felt as an OHT, we had the foundation to start looking at a more mature governance model and not have it as loose as at the time the ministry was announcing. We wanted to move away from specifically looking at organizational mandates to looking at the health of the whole entire community. And we knew that we would do that with a more robust and accountable model. So we felt that the not-for-profit corporation model provided more structure and accountability for us to start that work. We also wanted autonomy in operations, potential to receive funds, procure, hire into an organization, potentially one day become a health information custodian and deliver services. And then we knew that incorporation at a board of directors model was a model that organizations were already quite familiar with. So this was really quite new because we were bringing together multiple organizations to think about how we were going to be, a shared ecosystem moving forward. I will also say that our Ontario Health team has a wide array of partners, from healthcare partners to social care partners. Next slide, please. So we had several inputs into our governance work, and I'll highlight this at the end, that this was a huge undertaking that we were doing, throughout the pandemic. We first started with a smaller consultation with Ernst & Young, where we started to explore what were the models that would make sense. You know, no one's ever really done this before in Ontario in this way. So was incorporation going to make sense? A charity organization, a venture organization, or, you know, just actually going with the kind of collaborative decision-making process the ministry had set out. So we did a few months of actually just exploring the potential options. The second main input was that we decided to base our Ontario Health Team work off of health equity. We knew that people in our OHT population suffered at times a 13 to 15-year life expectancy difference based on where they lived. We knew that we were seeing poor outcomes when it comes to equitable health access. We knew that certain populations were at risk. So we really wanted to have health equity at the very start of all of our governance journey. And in 2021, we spent most of that summer doing extremely large, small, multiple kind of partner consultations to understand what were the pain points from our network organizations. You know, how were they feeling? Building up that trust was really important to us. Next slide, please. So like I said, our journey really began with health equity. We decided to do a 6-month kind of consultation with our community with the mandate of developing a framework and action plan in 3 specific areas for our OHT. Number 1 was, how do we deliver care to patients from a lens of health equity? Number 2, how were the operations of my own staff and the project management going to operate from a lens of health equity? And then really, we knew that we were going to be undertaking a governance redo. You know, how does health equity become part of the DNA and governance structure of our OHT? Next slide, please. So in June of 2021, we completed a really comprehensive health equity report that included 24 key recommendations on how we were going to move an equitable health agenda forward, including what would a board of directors look like? How do we include diverse voices? How do we represent marginalized populations that we know are suffering from inequitable health outcomes in our city? This report was completed by a council. It included 7 population-specific focus groups, 25 key informant interviews. We did extensive review of already developed local and provincial reports, and we also considered the applicability of the Ontario Health Equity Framework. Next slide, please. So then in the summer of 2021, our OHT staff led several partner consultations. Again, we wanted buy-in from our partners. We weren't going to go down a venture that everyone was really adverse to. You know, what were the pain points from people that were going to be part of this model? Did they see value? What could we help with? So we led those partner consultations over the summer, and we reported back on the findings of both reports, the Ernst & Young, where we went over several governance options, and the health equity report. We allowed partners to ruminate and understand the model and what the implications were. Our biggest questions through that time were, you know, how will this affect my own funding and my own board? But at the end of it, I will say there was less fear about coming together as a not-for-profit corporation than we actually expected. And because of the moment in time, we weren't asking organizations to give up their funding and cross-integrate and close down their shop and become part of a bigger entity. We're really starting the work by understanding how we're going to be this shared model moving forward. The unique thing right now about how healthcare is still structured under the OHT model is that the accountability and funding agreements right now still lie with the Ministry of Health. There are small testaments of change of how we've dealt with funding and decisions since then. But right now that accountability is still laying there. So it kind of gives us a little bit of a runway to test out working together and continue to build in that trust and relationship. Next slide, please. You know, who's going to be an incorporated member of our OHT? You have to be an incorporated entity already. You have to be in existence for at least 5 years, ability to demonstrate good financial standing. You're able to offer services that contribute to our care pathways for those of people living within our catchment area. You must declare the sector of membership for which you are applying, which I'll get to in a few slides. And then we're in the midst of developing a membership agreement. What does it mean? And what does the defining factors of being part of our incorporated work mean? Next slide, please. So how are decisions going to be made after we formed our incorporation? There is going to be 18 board seats. 15 directors are nominated by class or stakeholder councils, which I'll show in the next slide. We made sure that there was 3 independent directors to ensure that we're filling out our skills and competencies. And that was a big recommendation from our health equity report. And really, the directors are serving on behalf of the entire health of the community and not their organizations. Next slide, please. This is just a snapshot of kind of our current board structure. And you'll see that our project management office and my office reports into the board, but that we have 4 formal stakeholder councils. And really, these councils, they undertake planning and operations of our OHT, but they're also important because these are non-incorporated members of our OHT that form part of these stakeholder councils. But you'll see in the next slide, have a seat at our board. It's a little bit complicated because we didn't want to have, every individual physician signing up to be part of our incorporation, but we knew that primary care was an important seat. So primary care has formed its own council, and all of these councils feed directly into our board. Underneath that are several working groups. This is where a lot of the decision-making is actually being brought forward to the board. I'll say that within those working groups, there is, there's no delineation between whether or not you are a large organization or a small one. We work with anybody that is part of our integrated care models and a part of our populations of concern. And that ranges from small charity organizations, health providers, social providers, municipal providers. Next slide, please. This is the structure of our board. And you'll see here in the green, those are the stakeholder councils. And those were also decided because they were important levers for our success. I see in the chat, why does Haldimand have its own council? Because we brought in Haldimand post after us being approved, because they have their own unique local nuances, we wanted to ensure that there was a direct connection between that group and the formal board of directors. The board seats in the sectors were chosen based on our priority populations, based on our health equity report, and based on the fact that we wanted to ensure that there were empty seats to round out any diversity, any concerns about, changes in direction on Ontario health teams. We want to be able to be nimble and open to responding. As of right now, we are currently building up to this 18-member board. Next slide, please. So when I think about, key messages about our learnings about actually doing this model, individuals are not members, but they are part of those stakeholder councils and all of the working groups as part of our OHT. I do want to reiterate that any organization can be part of integrated care working groups under our OHT. And I feel like this is very important for true integrated care. We have seen enormous success by partnering with organizations that have never been part of the health space before. This structure is taking time to mature. You'll see it's been a few years journey, and because we're doing it for the first time, even just figuring out the legal aspects of what this means, bringing on the trust of the partners, and even just communicating the model to everyone in the area, has been, a lot of time and effort put in. Next slide, please. Continuing on the key learnings, it's resource intensive, not only in the development of a model like this, but in the implementation. We're still working through implementation. And for those familiar with the Ontario Health Team model in the province, they're not funded with a whole bunch of back office staff. At the heart of this, I have 8 full-time staff that get up and think about the Ontario Health Team every single day. So it's more complicated with the more partners involved, but it really does take a lot of dedication to moving this forward. I'll say that along the way, though, even though it's taken time, it really allowed us to have opportunities for dialogue and decisions in a new way. Nobody around the table has really formed an incorporation like this before. So we know it's not perfect. We know that it's going to take time, but already I can say from the board level, we're thinking in a more shared and collaborative way, less about those individual organizational mandates and more about the health of our entire shared population. And organizations are coming to the table about, well, what can I lend to the population health model? It's built a lot of trust. I'll say that, going back to, I feel the OHT model now is seen as the glue of the community, where our community and social partners are coming to say, here, I have a shared problem that needs cross-sectoral help. This is where we're going to go to. It is definitely a work in progress. It takes money and it takes staff time. We are still implementing that structure, especially since the staff team is so lean. But we were really, happy and surprised to hear that the Ministry of Health has chosen this model for all OHTs to move forward with in the future. I think that's it for me. I just leave the last slide with our connections. Please stay connected and happy to answer any questions.
Wow, fantastic. And we are seeing a lot of questions coming up in the chat, and I'm looking at the time going, I'm not sure we're going to get to all of these, but I will ask you, maybe Melissa, you could have a look back through some of the more recent ones, and there's a few kind of targeted specific factual questions. Jodim and I are going to want to bring back a more conceptual question towards the end after when we get into discussion. We could probably take these slides down now because we have the great pleasure of being able to speak now and hear from Donald Carty. As I mentioned at the beginning, Donald's been patient. You can see, Donald, there are some patients and caregivers in the chat out there, if you recognize the names and you've been able to follow along. Many people making some specific comments around, even in the most recent one, the role of patients and caregivers on that leadership council. That's a role that you have. So, I'm really interested, in some of your experience and what's important to you as a patient family caregiver about governance for these integrated networks that are not just about an individual provider, but trying to advance integrated care. Maybe you could share some of your experience, knowledge, and ideas.
Well, is it okay if I read what I prepared?
Yeah, please do. I think we had a chat, and I have some questions in case you didn't remember what we talked about.
Yeah, I worked on this, so I put this together. So I'll just go right ahead. I'll try to move through this as quickly as possible. So good afternoon, everyone. And I want to thank you all for this opportunity to share a few words from a patient, family, and caregiver perspective. We begin life with the most crucial of needs, attachment to a caregiver. This is the beginning of our fundamental need for belonging and connection. So let's you and I take a walk along this path. I would like you to envision that you find yourself outdoors in the forest all alone and you are ill. You are cold and it's raining. You're sopping wet. And as you slug through the muck and the mire, you stumble and fall. You look up and in the near distance, you can see a village, but there is no visible lights. How do you feel? As you get closer to the village, a light appears in the window of one of the homes. You knock at the door. Someone opens the door and says, "Come on in. You're welcome. Here's a fire you can sit next to. Here's some dry clothing you can put on. Here's a blanket. Here's a hot bowl of soup. You are safe and you will be cared for here." Now, how do you feel? You've gone from unhappy to happy in a very short period of time with very little things. As patients and families, we feel at times that we are in the cold, not cared for, and searching for that light. What does the light represent to you? Reflection of the landscape and environments of our health and wellness system of care. And you can fill in the blank yourself. Because of the multiple health concerns surrounding my dad, my older brother, my mother, and my work as a home care worker, the journeys through the healthcare system proved to be no system at all, but a group of services that at times really did not communicate very well between one another and with patients and caregivers. And through this experience, also dealing with the biases associated with race, cultural insensitivity, ageism, and the social determinants of health. I felt like I was seeing a systemic dysfunction of behaviors, attitudes, and an apathy that, in my experience, showed up as a labyrinth that was difficult for me to navigate and was almost incomprehensible to those in my care. I did not want anyone else to have to suffer the frustration and sometimes even the hopelessness of a system that was so focused on itself it had lost sight of what its primary focus should be. In an effort to devise a solution, I had to get involved. I first became a patient family advisor at the local hospital, shared my lived and living experience as a patient and as a caregiver. Through that volunteer position, I was asked to join a planning table tasked to define our population of focus, which led to an invitation to join the leadership table as a patient family caregiver advisor. Little did I know I would become an outspoken voice for the patient families and caregivers for that planning table, making presentation to the Ministry of Health on patient family caregiver experience in our community. The Barrie Ontario Health Team approval followed after 2 years of collaboration, connection, and consultation between local healthcare, community and municipal partners, patients, family, and caregivers. And now I sit at the table as a full partner and an elected tri-chair. During the height of the COVID outbreak and subsequent incredibly restrictive lockdowns in long-term care homes, of which my mom at the time was a resident, I immediately took my voice to a much broader community at large. And at one time I was engaged with at least 16 volunteer activities within the community, including city councils and writing opinion pieces for the local paper. I must admit, though, that at times sitting in these multidisciplinary meetings, including the ministry, was tough. I felt during many of these conversations, my mind was prompting me to ask, can I buy a vowel? There were so many acronyms, which did at times make me feel a little like an outsider, like I didn't belong and somehow not connected. I was coming from my heart and the lived experience, and it seemed that to me that everyone else was coming from the head and from within a culture of silos. At that moment, I thought to myself, breaking down silos is like trying to pin jelly to a wall. But we couldn't think outside the building. And I was immediately reminded of an experience I had in a meeting. In this meeting, the discussion was bogged down. We couldn't reach an agreement. I felt we were missing a crucial consideration, and I shared a comment. And this is what I said. We have a responsibility and a duty to care for frail seniors with respect and admiration for all that they have done for the generations that came after them. After the meeting, a doctor came up to me, excited and extremely animated, and said, I liked what you had to say. You know, I never thought of seniors in that way. Then he began to tell me of the changes he was going to make in his practice and care regarding seniors as a result of this new insight. Wow, what a small shift in perspective. Hippocrates said it's more important to know what sort of a person has a disease than to know what sort of disease a person has. As society has changed, parents, employers, teachers, and other traditional authority figures have become more flexible and collaborative. A growing number has come to expect the same of the healthcare system, from government to physicians and other healthcare professions. An important undercurrent in many contemporary healthcare trends is trust. From vaccine hesitancy to the rise of alternative wellness care rooted in a sense of affinity and community, healthcare choices are shaped by people's confidence in their care providers or lack thereof. I personally believe one simple imperative is emerging from these conversations: humanizing healthcare. Embedding the patient, family, and caregiver voice in planning and decision-making across the system is essential. Empowering patients, families, and caregivers by informing, involving, and empowering them. This includes strategies to build health literacy, to promote shared decision-making, to support self-care, and to encourage co-creation of services. I believe that humanizing healthcare also applies to governance that includes leaders modeling collaborative behavior, integrating diverse and inclusive voices, including collaboration, connection, and consultation between local healthcare, community, and municipal partners, patients, families, and caregivers across the spectrum of the Ontario Health Team model in a common vision and shared purpose. It's all about multiple perspectives being unleashed on what may seem to be intractable problems, and should engage a great variety of disciplines and the beautiful diversity that enriches the communities and landscapes that make up the communities within which we live and work. The future I see is one that embraces the compassionate appreciation of human values and of the unique ability of the human spirit to express itself in all areas of endeavor as giver, observer, participant, and receiver of healing services. As the greatest compliment you can pay anyone is by giving them your attention, I am grateful. I want to thank all of you for your remarkable resilience and your ability to address the challenges in a variety of areas that are essential to building a connected healthcare system. Our short walk together along this path has been a pleasant one to me, and I trust that I have not bored you, nor caused you to regret the acquaintance.
Wow.
Not a chance, acquaintance, you may rest assured. In closing, I would like to leave you with these few words. Don't walk in front of me, I may not follow. Don't walk behind me, I may not lead. Walk beside me. Just be my friend. Be the light. Thank you.
Thank
Wow. Thank you. And you are really getting a lot of thank yous. Bravo. Thank you,
Oh.
Donald. Thank you. That was wonderful. Standing ovation in the audience today. And people want your transcript. We'll see how we might be able to share that out. Certainly the video and what Donald just said is going to be available. Maybe we can, with Donald's permission, extract that out so it's specifically available. That was much more powerful even than our conversation, though I recognize a lot of the things that you said there. And I think, you know, interested in your experience, and I think we're gonna try and have everybody answer one question each now. And so I'm gonna leave it to Joe Deem to ask the first question of Donald here. Thank you so much, Donald. I really appreciate that. And
Thank you.
Thank you, Walter. Thank you, Donald. As I have been tracking the chats and everybody's contribution, and I'm in a very fortunate position to have worked with Donald side by side for, I think, 4 years now, if that's accurate. I want to ask you two questions, Donald. And I think everybody who's participated today will see their questions or comments in this question, but I'm framing it in a way because I know Donald well as Tri-Chair of Berrien Area Ontario Health Team. The first is, as a result of you being in an equal role in chairing the Ontario Health Team, what difference do you think it has made to the team? And the second to the team and to the impact with people and their families. And the second question is, how has the Berrien Area Ontario Health Team established trust with you?
Wow, those are, I'm still shaking a little bit from the response.
Take your time, Donald.
Yeah, I guess for me, it's been a pleasure serving in this way with the Ontario Health Team. It's a great team and a wonderful group of people, and they've done some incredible work, absolutely brilliant, every one of them. And I'm kind of low key usually. I don't really say much, but I do try to choose my words wisely because words do have power. And if I can put out some small suggestions or some kind words and try to keep those kind of things moving, I think that's kind of the driving force for me. I'm really a heart person, and I've also been, in my home care experiences with people from home to hospital, hospital to home, and sitting in emergency rooms or sitting with patients in their rooms. That certainly helped to inform me a great deal. And it's been my pleasure to be able to expand out to that as a result of my care for my dad and my brother and my mother, whom I just lost in October. Yeah, I don't know if I answered the question, but
I think that's incredibly helpful. And I know from joining you in those discussions that what Donald brings is also the ability to ask the question. And where are additional patient, citizen, caregiver partners? And please consider it from this lens, the heart lens, how am I going to experience this? What kind of impact will this make? And I'll say you fundamentally change the nature of the conversations and the path that is taken. So to everybody online, and of course, so many of you are talking about, oh, it would be good if we had a tri-partnership, or how do we ensure equal partnership? Donald has shared so much of the how and the difference it makes. And also on the IFIC Canada website, there's a session we did on how to co-design and share power equally with patient, client, and caregiver partners that can serve as a resource. Donald, on behalf of all of us, and you can see the response from the entire community. Thank you.
Thank you.
Walter, to you.
Thank you very, very much. I'm going to come back to Mirella at the outset, and I'm going to give you a really, really hard question, Mirella, because I think you can handle it. And I know it's you could go on for quite a while, but let's just try and get a bit of a snapshot of what does good governance look like, and how would we know, and how would we recognize, how would you recognize a good collaborative governance? And maybe in doing that, you might indicate how we at the Health System Performance Network, where we do a lot of measurement, might think about how do we measure good collaborative governance?
Well, that's indeed not an easy question. Well, I think it's good governance in this way, and collaborative governance is about balanced governance and inclusive governance. So I think that's one of the major issues. So I would say looking at the balance between how people are involved, in what way are they involved, is it clear how they can be involved, is there room for this discussion, is there room for decision making, is it clear why it is arranged the way it is, and is it suitable, the aim you have together, you're working on. So that's maybe not a very concrete or a specific answer, but these kind of aspects I think are important, more important than what kind of, well, legal structure you choose, what kind of arrangement you have, because there, before you make the choices, you have to make these kind of, you could say, basic elements really thought through with the people you're working with or the organizations you're working with, and then make good choices and see if it's works the way you want to work.
Thank you. I hear inclusiveness, voice, and transparency and communication amongst other essential elements there. So it's a few things.
Yes, that's correct. But it's also about, I think, the inclusiveness of the different roles. So also of the different roles of, for instance, supervisors, the leaders, finances, etc., because they are also related to making it happen in a good context where incentives also work towards the collaborative governance to really make it work. Okay,
I think we're going to need a masterclass on this. This is a really in-depth piece. And so I look forward to that. We may not get to questions for all of our panelists today. I think, Jodine, you have one more thing to close off. I'm very conscious of our time here as well. So it's such an expansive discussion.
So let's do this. Conscious of time, and we like to stay on time. If you have to leave right now, before you log off, please share one word in the chat that describes your experience today. We like to track, what was this session like for you? We will send the poll out to see if you changed where you felt your understanding was around collaborative governance. And for those who wish to say, look at that, motivating, anchoring, inspiring, very beneficial, inspired, thank you for the openness, refreshing, encouraging, illuminating, inspiring, wanting more and more and more. Okay, so we're gonna look at a master class for all of you, just incredible. You know, this is the most validating. I know as each presenter looks at all of this, we are all touched because we know just by convening and sharing and curating this material two-way with all of you and with all of us, it has a huge impact. So we will invite you to stay, to join for our next sessions, increased knowledge and understanding, very diverse and exciting, trusting. We took a radically collaborative approach. We hope you will use all the resources. Team, I think we should call it. But Melissa, one of the things I did want to ask, and it came up time and time again, is how you build trust with people who feel they don't have perceived power. Smaller organizations, smaller budgets. You did talk about shared decision-making around collaborative governance, regardless of size, but we still have perceived power differentials. So feel free in the chat to share some of that, and we will include it. And for everybody, it was such a pleasure for Walter and I. We will follow up with the poll. We will follow up with resources. We will follow up with a link to our website where you'll get the entire presentation from today. And to Mirella, Melissa, Paul, Donald, incredible. Thank you. Walter.
Thank you all very, very much. Appreciate it very much. The International Foundation for Integrated Care Canada will be back in March with another special event on advancing integrated care with digital health. In February, in the meantime, we will return to HSPN's monthly OHT webinar talking about population health management for individuals with diabetes. We have several new reports that are up on our website. We'll be sending out information for you to collect those. Information about also some other research that's going on, led by Dr. Carrie Kolusky around person-centered care, particularly in frail populations. So please watch for those invitations. Thank you so much for coming today. Appreciate the goodbyes. Appreciate the words in the what today meant to you. And with that, we'll leave it off. Have a lovely afternoon.
Warm hugs, good health, and a good rest of the day. Look at that.